But Anne-Marie, are you ready? Are you available?
Yes, I am.
Wonderful.
So yes, first of all, I would like to thank you very, very much for this very inspiring session, I would say. I think it is great to have this discussion, and I'm very honored to contribute to that. So what I will do in the next 15 minutes is the following. I will explain to you quickly how I got involved in clitoral reconstructive surgery. I will provide a short introduction, spend a few words on the legal framework, also the current evidence about clitoral reconstructive surgery, the guidelines that exist, and also my reflections on that after I did some research and my conclusions. Now, how I got involved. In June 2014, I was invited by the Conversation UK to interview Dr. Marcy Bowers from the United States, who performs reconstructive surgery. And I wrote an article that was published in the Conversation. In September 2015, I completed my PhD research on FGM. So I looked at FGM from a human rights law perspective. I did some field work in Senegal, and I also met some surgeons in the African context who performed the surgery, and hence my interest. Now, in October 2018, there was a debate in our parliament about reconstructive surgery and whether or not this surgery in the Netherlands should be paid by health insurance or not. And then I heard some parliamentarians say things like, there is a lack of scientific evidence about the effectiveness and the consequences of the surgery, and also an unacceptable complication rate. And that really sparked my interest, since I knew quite a lot of women in the Netherlands who had the operation themselves, and they were very positive about the operation. So what I did is, in December 2018, I started a research on the effectiveness of clitoral reconstructive surgery. And I conducted quite some interviews with women who underwent the operation themselves, because I wanted to hear from them their experiences. And in October 2019, I published an article in Dutch in a doctor's magazine that has been quite influential in the Netherlands, with the title "Clitoral Reconstruction After FGM Should Be Covered by Health Insurance." And I think that says already something about my main findings, and I will show you why I came to that conclusion. Now, in January 2020, I received an invitation of Dr. Pierre Valdez to come to his clinic, and here you see a picture with his wife, with whom he is running his clinic, and also with Dr. Rifat Karim, who is the surgeon who performs clitoral reconstructive surgery in the Netherlands. So the operation is offered in the Netherlands since 2010, and he has operated about 60 women in the Netherlands in the past 10 years. What I found when I was doing my research in the Netherlands is that there is really a lack of knowledge. So there is a lack of knowledge about the operation among women, but also among health professionals. So there were many gynecologists, many surgeons, many GPs who had no knowledge about the operation. So what I decided to do was to develop a brochure, a flyer, with a very essential information about the surgery. And I also developed a website where people can find more information about the surgery. So I'm an academic, I have my own PhD, but I find it really important to translate academic knowledge to a more, practical sense that many people can use it. So that's what I thought, let's start here. I think sharing knowledge is key, and that's why I developed also the Clitoral Reconstructive Surgery Knowledge Platform. So I developed a website in Dutch, and my plan is to also develop a website in English to share knowledge. But that is a bit how I became involved in this topic. Now, as was also shared by the previous speakers, there is an increasing demand for this operation, and there are at least 10,000 women who have undergone the operation already over the past years. The operation is available in Europe, in the United States, but also in some countries in Africa. Here you see a list of countries where the operation is covered by national health insurance. So that's in France, in Belgium, Germany, Sweden, and Switzerland, but not in other countries. I think this is already covered by the previous speaker, so we know what the impact of FGM is and also how it relates to sexuality. One thing I would like to highlight that indeed not all women who have FGM experience sexual problems. There are many studies that indicate that women are still women who have FGM are still able to experience a psychologically and physically fulfilling sexual life. So I think that is really important to mention. I was asked to share something about the legal framework and clitoral reconstructive surgery. And I think there is a very important difference with cosmetic surgery, namely that clitoral reconstructive surgery has the aim to reconstruct a damaged organ, not to operate an organ that is intact or that is healthy. And I think it's very important to take that into consideration. And therefore, all European laws, including the UK law, permits clitoral reconstructive surgery. So that's very easy. We could be very clear about that. Something I want to highlight is current evidence, because I think there is a lot of misunderstanding, there is a lot of misconception, and that's why I did my research. So I developed this table where you see which columns I included. So the author, the title of the article, the year of publication, the study design, the expectations before the surgery, the benefits, and also the complication rate. Because I thought, I have no interest myself whatsoever. I only want to learn about the operation. I want to see what current academic evidence says about the operation. And what did I find when I included all studies that I could find in this table? The motivations for clitoral reconstruction is, in the first place, and this has been highlighted already, is the restoration of female identity. So I think this corresponds also with your experiences, that many women might come to you with the request that they have the feeling that their sense of womanhood has been stolen or taken away, that they wish to feel complete, a real or a full woman. And what is important is that this aspect, so the restoration of female identity, has not been recognized in guidelines as an important element. And I think that is problematic. Another motivation, as was also highlighted by Yasmin, is the restoration of sexual pleasure and also reducing pain. So if you look at the studies that have been done about the motivations, those are the top 3 motivations of women why they want this type of surgery. Then we come to the effectiveness of clitoral reconstructive surgery. Now, existing literature, so if I look at the columns in my Excel file, it really shows a positive trend in the results. So the visibility of the neoglans, so the neoglans is visible after the operation. There is a clear improvement of sexual function. There is a decreased vulvar pain, improvement of clitoral function, and an improvement of body image and psychological well-being. So this is what the literature shows. There are also complications, as Yasmin also highlighted, and I listed them here, but it is important to realize that those are minor complications and that the complications rates are also quite low. And that brings me to my next point. So I included in my literature review all existing evidence. Now, there are some methodological limitations. So all the literature that I have studied and that I have analyzed has some limitations and shortcomings. In the first place, we have a relatively low number of patients because, as you can imagine, the total amount of women that want this operation and the amount of women that you can study is relatively low. So that is a shortcoming, but that is also because, you know, this type of operation is very different compared to a knee or another type of operation. So I think it is inherent in the operation that it is offered. The follow-up time up to now is relatively short. There is also a high loss of follow-up. Some studies use non-validated scales. There's also a risk of bias due to participant selection and not having a comparison group. So I'm very much aware, and I want to highlight that there are shortcomings in existing research. However, what I think is important is, despite all those shortcomings, the existing literature shows a common positive trend in results. Now, if we take that into consideration and we move to the guidelines, as Yasmin also highlighted, WHO guideline didn't issue any recommendation. So it says, due to the lack of evidence and safety concerns, the GGG decided not to issue any recommendations regarding these interventions at present and strongly encouraged further research in these areas. Furthermore, the same WHO guideline says that the evidence for all measured outcomes was rated as being of very low quality. It also says that 3 studies reported complication rates that fluctuated between 5.3% and 23.6%, and that there are unacceptably high rates of reported complications. We also, well, let me first reflect on this, because the WHO guideline is based on a systematic review of 2015 that found 269 articles, but only included 4 studies. And I completely understand why those 4 studies were included. However, it means that 265 studies were put aside. And the outcomes of those 265 studies is very positive. And I think people need to be aware of it, that this is the case. In addition, the complication rates of 23.4% and 23.6% that are mentioned in the WHO guideline do absolutely not correspond with reality. If I then move to the Green Top guideline in the UK, similar conclusions are reached. So the clitoral reconstruction should not be performed because current evidence suggests unacceptable complication rates without conclusive evidence of benefits. And I think this is really problematic. If we then move to the Dutch guideline, it goes even worse, because in the Dutch guideline, there is written that 22% of the cases, there is a deterioration of sexual function after clitoral reconstructive surgery. When I read this, I really started to be very worried, because when I dove into this 22%, and try to explain it to you how the Dutch came to this conclusion. If you look at the study of Dr. Pierre Valdez, he has studied about 2,000 women in his study, and he rated those women of before the operation having good, in a scale of 5, good until not good sexual pleasure before the operation. Now, there were a few women who already had a very good sexual pleasure before the operation. So of those, that very small group, 22% of those women didn't have an improvement of sexual pleasure after the operation. Now, in the end, what happened in the Dutch guideline is that there is written that 22% of all women who ever had the operation have a worsening of sexual function after the operation. And I think this is really bad. I think if you use scientific evidence this way to make your point, it is very problematic. So now my reflections. The problem is, in the first place, that the medical establishment is very skeptical. Some medical experts say that Valdez claims are anatomically impossible in case of type 2 FGM. And I think this is also how this webinar started, that there are quite some misconceptions about FGM, that not the whole clitoris is cut away when you have undergone type 2 or 3. And this observation, that was a formal reply to the study of Dr. Pierre Valdez, is based on wrong assumptions and also a lack of scientific knowledge of FGM. And I think we should really make sure that everybody has good scientific knowledge about the anatomy of the female genital organs. In the second place, some medical experts describe the procedure as a novel procedure or as a new technique or a recent surgical technique with limited amount of poor evidence. However, it's not a new technique. The first known surgical procedure on the clitoris dates back to 1930 and is known as the Halbjan Narajani procedure. And I think Dr. Yasmin Abdulkadir can confirm that the operation is not a difficult procedure, but a simple technique. If you're a good surgeon, it is not a very difficult procedure. Now, existing guidelines, as I tried to explain, are not aligned with scientific evidence. What I believe should happen is that healthcare professionals should perhaps be more open-minded, non-judgmental, and culturally sensitive in their approach to these women, and also explore the need for surgery. I completely agree with all the previous speakers that highlighted the importance of of different types of care. So I completely agree with everybody who says that this surgery is not a solution to each and every problem, but I will come to that in a minute. But let me tell you this. So I'm a human rights lawyer. And if we look at FGM as a human rights violation, to my mind, it's really hard to argue that on the one hand, FGM is a human rights violation. European countries put a lot of money and effort into ending FGM in Africa, in Asia, in the Middle East. However, if we have women in the Netherlands, in the UK, in other European countries who had psychosocial counseling, who tried other ways to improve their sexual pleasure, but who want to have this operation, that we tell to these women, sorry, we have this operation. We have evidence that this operation is effective, but you need to pay for it yourself. I think this is not a right way of looking at things. And that's why I think if you look at FGM from a human rights law violation, if you look at the SDGs, if your sentence is like leaving no one behind, I think we should really consider how we look at the operation and how we look at women who want this operation. I believe that any well-informed and competent adult women should be free to make a choice for reconstructive surgery after FGM. I think the surgery should be covered by national health insurance in all European countries. And therefore, it's important to take the following into account. So not all women, only a very small group of empowered women want this surgery. So that I think is important to take into consideration. I agree with everybody who was all the previous speakers that a thorough patient selection is key and that the operation is not always necessary to address the needs of these women. So there are quite some studies that show that multidisciplinary care sometimes meets the women's needs and then they decide to refrain from surgery. And I think that is a very good thing. Counseling and managing the expectations is fundamental. So we need to take that, of course, into consideration as well. Let me then get to my conclusion. I'm very happy with the webinar that we have today because I think it is crucial to have a well-informed debate about the surgery. not a debate based on opinions, but based on facts and scientific evidence and knowledge. I think it is important to look at the surgery in an unbiased way. So survivors of FGM are very often portrayed as vulnerable women, especially in the literature about FGM reconstructive surgery. But my experience is that these are instead very strong women who are able to make a decision, who know about their sexuality, and who want to have it restored. A problem is that in the EU, we have a large variation between countries. So in some countries, it is covered by health insurance. In other countries, it's not. And I think it should be better harmonized. The main problem is a knowledge gap and also a lot of misinformation. And I try to address this issue with this knowledge platform that I'm currently setting up. My aim is to share knowledge to survivors of FGM, to health professionals, to policymakers, in order to make sure that, you know, we have this debate, we talk about reconstructive surgery based on evidence and facts. And I would like to thank you very much for your attention.
Thank you, Anne-Marie. That was amazing. And I, for one, am going to be going to your website very soon to have a look. Perhaps, I don't know if we need a link to it, or if we can access it quite readily. Perhaps it would be good for you to put that in the chat for me, just how we could get to your platform. But I think it sounds brilliant, and I think we need something like that here. You've got my mind whirring. Thank you so much for talking to us. Please, if you can,